I'm coming up on my 14th year full-time EMS work, and in particular because of my role in a fire department that provides paramedic intercepts to half of a county, I have been, I guess, somewhere between 100 to 200 cardiac arrests. And cardiac arrest scenes always, to me, feel very chaotic. You're getting information from 100 different sources. People are shouting at you from different directions. You have AEDs that are still talking to you when you get on scene. Family wants to give you information. Bystanders want to give you information. It is an extraordinarily difficult environment to remain calm and to make good, solid decisions. It's particularly important because you have a human being here that is in cardiac arrest. You have a crew that is trying to do their very best. You have family that is hoping for the best possible outcome. All of these things add to the stress and the difficulty in making decisions. And on top of that, there are a lot of legal implications for some of the decisions that we're making. A very tough environment to work. I'd like to take the opportunity to delve into a topic that makes EMS a sometimes legally complicated occupation for us, and that's the Do Not Resuscitate order. You need to think about Do Not Resuscitate orders ahead of time because in EMS, as you're aware, oftentimes we're meeting the patient for the first time. We've never met them before, we don't know them, we don't have their history, and time is of the essence because they're in the middle of a medical crisis. Either the patient is already in cardiac arrest and family is calling, or it's somebody who is rapidly approaching death or teetering on the edge. They may die, they may not die. And when we get there, we don't often have a lot of time to get history and wishes and take a poll of what everybody wants done on the scene. And when it comes to cardiac arrest, irreversible brain damage can happen in as little as 6 minutes. You think about the family recognizing a problem, calling 911, speaking to the 911 operator. The 911 operator then pages us out. We get in our ambulance. We respond to the scene. If the patient is not in a condition in which they are simply risky for death, but they're actually in cardiac arrest, you've already burned that 6 minutes off, and there's really little to no time to act. So we need to think ahead of time about the DNR in order to be able to act quickly. Some states, including Wisconsin, have attempted to simplify the decision to act or not act in the case of cardiac arrest by having a DNR bracelet. So I ask you this question. Is it true or false? If the patient doesn't have a DNR bracelet, they're not a DNR, period. Truth is, it's just not that simple. As much as the state was trying to help things by having a DNR bracelet and have that be the only legally binding document or proof of a patient's wishes, it just doesn't work that way. So let's talk a little bit about the DNR and what the legal issues behind a DNR are, and then we can get to finding out how we should act at Lifestar EMS. A Do Not Resuscitate order is a written order issued according to the Wisconsin Chapter 154, which addresses DNR orders and how we are supposed to respond to it. It is a directive for emergency medical services, EMS responders, and emergency healthcare facility personnel to not attempt cardiopulmonary resuscitation on a person if there is an order issued or if that person suffers cardiac or respiratory arrest. So what does that mean when you do not resuscitate? What are we do not doing? Well, resuscitation means cardiopulmonary resuscitation or any component of it, including cardiac compressions, ET intubation, or any other advanced airway. That might be the King airway, it might be a combi tube, it might be an iGel. Any artificial ventilations, the bag valve mask, and providing external ventilations for a patient is prohibited if there's a valid DNR order in place. And any electrical therapy, defibrillation, or cardiac resuscitation medications, and similar invasive procedures. That does not, however, refer to the Heimlich maneuver. If you have an obstructed airway, we are permitted to go in and remove the obstruction from the airway. This is a mandatory thing, the DNR orders. So, except as provided in a few circumstances, healthcare responders, emergency medical responders in healthcare facilities shall follow do not resuscitate orders. And that shall follow means it's mandatory legally on us. We don't have the option of making a decision about whether it's the right thing or the wrong thing to do. If there is a valid DNR in place, we are required to obey that DNR order. When do we not honor the DNR order? Under Chapter 154, if the order is revoked, and we can talk about what that means to revoke the DNR order in just a moment. A second case would be if the DNR bracelet appears to have been tampered with, or if it's been removed from the patient, then we do not honor that DNR order, except for some circumstances I'll describe in a minute. And then, interestingly enough, if we know for a fact that the patient is pregnant, we're not supposed to honor that DNR order either. So how do you revoke a DNR order? If the patient expresses on their own their desire to revoke the order, that's enough. So if the patient is still alive and you ask them what their wishes are, and they say, I want CPR, I do not want you to obey this DNR order, then it's okay to ignore the DNR order. And then we are authorized, or the facility that they're coming from, or family member, or a healthcare agent can remove the DNR bracelet. And then we're also supposed to notify the patient's doctor that they have revoked that order. If the patient defaces or destroys the DNR bracelet, that is considered proof of revocation. If the patient removes it, or the patient has an agent that removes it for them, that is considered revocation of the DNR order. And there are some penalties associated with making the wrong decision here. So this is the legalese on the left, but basically, if you willfully damage that bracelet intentionally to either to attempt to make it look like it's revoked when it in fact is not revoked, that is a crime punishable by $500 fine or imprisonment for 30 days. To create a situation that makes a patient look like they're a DNR when they are not, or to make it look like they've revoked their DNR when they have not done that, that is actually a Class F felony. Very serious crime there. And then a forced DNR is also not allowed to happen, which means you're not allowed to require a patient or the patient's agent to sign a DNR order in order to receive services. So you couldn't have, for example, a nursing facility say, we only accept DNR patients. You're going to have to sign this DNR order in order for you to be a patient here. They are not allowed to do that. That is also a Class A misdemeanor. So what are we looking for when we're looking for evidence of a DNR? The easiest and simplest thing to look for and find would be a DNR bracelet. On the left, we have the paper form bracelet that is frequently wrapped in plastic. It has to have the state of Wisconsin seal on it. It has to have the name of the patient. It has to have the name and signature of the doctor. If that bracelet is present and on the patient, then we have to honor that DNR. What happens, as so frequently occurs, you're in a skilled nursing facility and they hand you a folder with all the patient's paperwork, and you open up the folder to read about the patient, and clipped to the front of that folder is one of these state bracelets. What do you do then? Well, it's certainly strong evidence that the patient is a DNR, and probably the patient or the patient's family or agent do not want a resuscitation performed on them, but it's not a bracelet on the patient, and therefore there's no legally binding reason to obey this DNR order. The facility will tell you sometimes, well, just go ahead and put the bracelet on them. That creates a very murky legal conflict of interest for you, because you putting a DNR bracelet on your patient could be interpreted by somebody else as you not wanting to do your job if the patient goes into cardiac arrest. So it's always been my practice and the practice of most people I work with to refuse to put the bracelet on the patient. The facility can do that for you, or you can rely on paperwork, and we'll talk about that in a moment. The DNR paperwork also that has this bracelet also includes an order form so they can order a more durable bracelet, and that's what you see on the right. These are legally binding DNR bracelets. They are put out by commercial operations. You can order them at Walgreens, and there are also online ordering or by mail ordering options in the DNR form. So either one of these bracelets properly affixed to the patient is a valid DNR order. Oftentimes we open up that folder and instead of finding the bracelet, we find this DNR form, which is real common. This is a standard state of Wisconsin Chapter 154 form. We can zoom in a little bit here. And there is the Do Not Resuscitate Order. It even lists the kind of things that we are not to provide on the right side, and on the left, comfort care that we are still to provide. It's not prohibited by the DNR order. Sometimes we'll open up that paperwork and we'll see something a little different. This, for example, is a 5 wishes form that's provided by Advocate Aurora Health to their patients. You'll notice that here they indicate whether they want CPR attempted or they do not want it attempted, and this is one of many pages of advanced directives and the kinds of things that the patient wants to indicate should or should not be done. These are great for healthcare facilities because they have the time to read all this ahead of time, but when we walk in the door and the patient's already in cardiac arrest, it's a real tough job to read through all of this paperwork. However, if you can flip forward to the CPR section and see which box is checked, that can help you make a decision on the fly. What's the difference between an advanced directive and a DNR order, and can one replace the other?
Hi, my name is Michelangelo Mortellero, and I'm an elder law attorney with Mortellero and Sinodinos in Tampa. Today we're going to talk about the DNR and how that DNR differs from a living will. Many people believe that they want both of those documents, and they are generally mutually exclusive in that you will want to make a decision and pick one over the other. So first let's talk about the DNR, what does it do, and then we'll talk about how that differs from the living will. A DNR is a directive that is signed by you and your physician that says you do not want to be resuscitated in the event that you code or your heart stops beating. And that can be from anything, that can happen anytime from whether it be a heart attack or whether it be on the operating room table, anything like that where they might have the possibility and the potential of CPR, paddles, anything that would get your heart going again and effectively bring you back to life. This directive will tell them that that is not what you want. So if your heart stops beating for any reason, they will not bring you back. So that is the DNR, and then we're going to talk about how does that differ from the living will. Well, with the living will, the directive only affects the decision to keep you on long-term life support or take you off of long-term life support. However, the doctors and the staff will always do everything to bring you back, get your heart started, and put you on a machine temporarily to allow you to get as good as you're going to get and to evaluate you and determine whether you have a medical probability of ever getting better, getting stronger, and coming off of those machines, whether it be kind of feeding tube or ventilator. So with a DNR in place, we never get to that point of bringing you back, stabilizing you, and evaluating you. We typically stop at the point of coding or the heart stopping. So why would you choose one over the other? There are several factors to consider. One is your current quality of life, or your quality of life at the time that the event happens. So I'll use my grandfather as an example. Suffered for several years from COPD. Every breath was a struggle for quite a while. And his last visit into the hospital, he said, if something happens to me while I'm here, I honestly don't want to come back. And because if I do, I'm going to come back to a daily struggle and pain and suffering. So I'm making the choice that if something happens to me, let me go, don't kickstart the heart again, and that's what he wanted. And I think that was the right choice for him. The beauty of estate planning in general and planning for long-term care is that you're in charge. You get to make the decisions. And some people say, bring me back and do everything you can, because maybe they'll come up with a cure for whatever I have. Perfectly fine. If that's your choice and that's what you want, then that's exactly what we're going to give you, versus the person that says, I've had a good life, I'm ready to go, don't bring me back. Another thing to consider is age. One of the things I've learned from working in conjunction with Gulfside Regional Hospice is that as you get older, things like osteoporosis do affect your whole body, and things like chest compressions and CPR for an older person in their late 80s or 90s might actually do more damage to them. And while technically they might be able to get the heart started again and bring you back, the damage suffered by cracked ribs, punctured lungs, things like that, may ultimately prove to be terminal later on down the road anyway. So it is one thing that you want to consider, not only what your wishes are, but where you're at in life, and what might be the consequences of heroic measures to bring you back. That is a good discussion to have with not only your family, but with your elder law attorney, and be educated on what happens, what are the options, what are the risks, and then ultimately make the decision that's right for you and your family.
That's a good description of the difference between a living will and a DNR. But what about some of the more outlandish things out there? For example, what if the patient has a DNR tattoo?
Doctors at a Florida hospital were faced with a very difficult decision when an unconscious man arrived in the ER. The tattoo that he had read, "Do not resuscitate." The word "not" was underlined. You may all have heard this story. This was a 70-year-old patient, had an elevated blood alcohol level, a history of very poor health, no identification, arrived with no family or friends, so all the doctors had was this tattoo. Doctors, clearly perplexed, weren't sure what to do, and I will say this, doctors are almost always going to err on the side of over-treatment. But this guy turned out had COPD, diabetes, atrial fibrillation. So the docs, unsure what to do, actually brought in the ethics committee. And the ethics team advised them to honor that tattoo, that it did express an authentic preference. This is another example of not a lot of great precedent in terms of what to do here. I think this was the right decision, because it turned out that he did have a formal DNR. It took them, of course, time to get it, but what would you have?
I think they were on a very slippery slope. You know, the law in every state allows us to consent to a DNR, but every state has specific requirements, whether it's 2 signatures or a notary. So I think the hospital did the right thing only because they were able to dig up
that was
after the fact.
But they had information that one existed. So often a family member in a hospital would say, oh, he does have a healthcare proxy, or he did consent to a DNR.
As an ER doctor, I can tell you almost always people show up. If you're unconscious in cardiac arrest, no one knows who you are, you never just have a DNR order hanging out in your back pocket. So this happens over and over again, and so often, because we always err on the side of overtreatment, there's no formality other than this piece of paper that almost no one ever has, unless you're in the hospital that you regularly go to, or you come into the hospital from a nursing home or some other facility. This happens over and over again, and I almost feel like this case may actually prod us to further think about what would be something that you could have on person at all times. We have medical bracelets now.
I love the bracelet.
I do too.
I love the bracelet because you can take the bracelet off. You know, what are you going to do if you change your mind about the DNR? They say it would take 8 to 10 treatments at $150 a pop. So maybe I just take a Sharpie and put an X through it, or cover it with electrical tape. I mean, it's silly on the one hand, but I agree with you. It's causing us to think about it, and I think a bracelet.
Patients write messages to me with Sharpies all the time.
Really?
Like, make them perfect, please.
Make them perfect, and then you do. So you listen
You
to that.
make them perfect, and I will love you, doctor.
But this is interesting because in a review of the literature, they did find an instance where someone had a DNR tattoo, but it was no longer their intent.
Too often the worlds of medicine and law do not intersect at a happy place, because here's the other reality. You know, in our country, a ton of resources and dollars
I know
are
where you're
spent
going.
in what we call feudal care, which it turns out most patients often don't want. And it's because we have a very hard time fulfilling the wish of someone who doesn't want things done to them. And so if you are someone who does not want resuscitation, you have to carry it in your purse, on your person at all times, because at this point in time, it's the only way you know your wishes will be.
But I think
Such a great point. We're damned if we do and we're damned if we don't.
It's a
We have an obligation as a doctor to do it, but you're getting into it that if we do it and we save somebody who did not want to be resuscitated, a big bill is generated.
I think the converse is more troubling, and I think the elephant in the room are the rotten attorneys and the malpractice. So my advice to medical providers, you know, my husband's an MD, and every morning I tell him as he's leaving, don't get sued today.
Well, as it gets more and more confusing, let's talk about what specifically we are required to do here at Lifestar. If you turn to the Do Not Resuscitate or Withholding Resuscitation section of our pre-hospital protocols, you'll find this page. And you'll see that it starts off at the top, recognizing that it can be complicated. If at any time you're not certain of which of the policies apply, begin treatment and contract medical control for orders. So we have all the numbers right here, and you are expected to partner up with a doctor if it is at all confusing or there's any kind of conflict or legal question as to the appropriateness of continuing or discontinuing resuscitation. At the bottom of the same page, it says patients with DNR orders who are not in cardiac arrest should receive supportive care en route to the hospital. We don't withhold treatment. We don't withhold oxygen. DNR means do not resuscitate. If they're not in cardiopulmonary arrest, the DNR order does not apply. DNR does not mean do not treat. It means do not resuscitate. And then it indicates straight out of the Chapter 154 for the state what a valid DNR order is. What does our medical director want from us? When we asked this question directly of her, her response was to use our best judgment. And whenever in doubt, and this is on any circumstance, not just do not resuscitate, but whenever in doubt, call medical control and partner up with them. We are permitted to accept facility paperwork if there is a clear case that the patient's wishes have been expressed. So whether it is a bracelet, or whether it is the official state DNR form, or whether it is other paperwork from whatever facility they're living in, if you can discern from the paperwork and the circumstances in which you find the patient that the patient would have preferred not to be resuscitated, you are permitted to honor that paperwork. Again, use your best judgment, but we can accept paperwork as long as it creates a compelling case that a decision was made with the consent of the patient or the patient's agents to withhold resuscitation. Again, in doubt, go ahead and call medical control and partner up. If you're not in doubt, we trust that you're going to make the right decision based on the paperwork that you're handed.